Okay, hello everyone. Welcome to our webinar session on the basics of monkeypox. My name is Issa. I'm a junior medical doctor and lecturer currently practicing in Ethiopia. So today I'll be moderating the session. Our guest speaker today is Dr. Tinsae Alemayehu. Sorry, once. So Dr. Tinsae Alemayehu is a consultant pediatrician and a pediatric infectious disease specialist at American Medical Center in Addis Ababa. He also holds an adjunct associate professor position at Hospital Millennium Medical College. Apart from his clinical practice, Dr. Tinsae conducts research in the area of expertise, with his interest being in antimicrobial stewardship in childhood infections. He has published more than 37 articles in peer-reviewed journals. Dr. Tinsae serves in the editorial and review boards of various journals and consults national and continental organizations in outbreak control and prevention. Dr. Tinsae will be discussing the ongoing global outbreak of monkeypox, principles for the management and prevention. So before starting our session, I would like to say thank you everyone for joining in. And so the first part will be presentation by Dr. Tinsae, and then we'll continue with Q&A session with Brooke and I will be moderating the Q&A session. Without further ado, I will leave the stage to Dr. Tinsae.
Okay. Thank you, Dr. Ipsa. Good afternoon, everyone. Welcome to this month's DENAWAC and Ethiopian Medical Association webinar on the basics of monkeypox infection, the currently pertinent worldwide outbreak that has been going on now for a number of months. So today I'll be discussing on a general introduction on the monkeypox virus and its history and also its clinical presentation, epidemiology, and if you encounter such an infection, how to evaluate it, manage it, as well as prevent spread to unaffected people. So monkeypox virus is a member of the family of viruses called pox viruses. These are DNA viruses. So overall viruses can be DNA as well as RNA viruses. It's of the genus orthopox virus and the family Poxviridae. This syndrome and most of its brothers and sisters in this family are transmitted by contact routes whenever there is a break in the skin or mucosa, and less commonly also via droplet routes. Okay, so as I was saying, there are 7 pox viruses which are of significance to human beings. So the first, historically, the well-known member is called variola or smallpox. Fortunately, this syndrome has been eradicated in 1980 with the last known case being diagnosed in Somalia. The second syndrome, pox virus syndrome, is called vaccinia. So this syndrome mimics the actual smallpox infection, but it is due to, it's a side effect of a smallpox vaccine administration. So consider it as a less severe form of smallpox. And obviously, since we don't have any smallpox now, the chances of having such vaccinia or dermatologic syndrome associated with the smallpox vaccination are also very rare. Then you have monkeypox, the topic of our discussion today, cowpox, parapox, or it has also another terminology called ORF, molluscum contagiosum, and a rare variant called yatapox. So monkeypox virus, it's a misnomer actually, because the labeling of the syndrome is because it was first detected in monkeys. But as I will be discussing a little bit later, it can manifest in any non-human primates as well as other wild animals. So it was first detected in humans in 1970 in the Democratic Republic of Congo in a 9-month-old boy. So 2 years earlier, at the area of the DRC where this child was diagnosed, smallpox had already been eliminated. So when this child presented with a smallpox-like disease, where no more cases of smallpox were being recorded, then scientists tried to isolate the molecular pattern of this new virus and then discovered monkeypox virus. So monkeypox is endemic to the tropical regions of Central and Western Africa. So until this year, the two strains of monkeypox were labeled as the Central monkeypox, Central Africa monkeypox variant and the West Africa monkeypox variant. This has been changed into new terminologies, as I will be discussing next. So the one country that experiences both Central African variant and West African variant is Cameroon, because half of its territory is within Central Africa and half of it is within Western Africa. So the Central African variant, or according to the new terminology, monkeypox virus clade 1, causes more severe disease, more fatality, and more transmissible. Thank God that this is not the cause of the current worldwide outbreak. The current worldwide outbreak is due to clade 2 and 3, or previously called West African variant. It causes less mortality of about 1% of affected individuals. So as I've already said, it's not only monkeys, rodents, non-human primates and other wild animals are likely reservoirs. So after biting or after scratching, or in communities where they like to consume partially cooked bush meat or raw bush meat, then monkeypox thrives. So especially people living near and around forests may have such high risk exposure. The incubation period is roughly about 1 week, but it can extend between 6 to 13 days. And monkeypox is predominantly transmitted via the contact route. And the second most common route is the droplet route. And rarely it can also be transmitted via the aerosol route. If a patient, for example, is admitted to the hospital and is subjected to aerosol generating procedures, then definitely the healthcare professional taking care of that patient, if not properly protected, then they can acquire it through aerosol route, but that's not a common route of transmission. And also, again, very rarely congenital monkeypox through mother to child transmission can also occur. So transmission mainly occurs if you have prolonged close contact with a symptomatic individual. But if you have minimal contact, and if that contact is not that close, you are really not classified as a contact, and then are not going to be subjected for immune prophylaxis or other methods of prevention. So human cases in Africa, they occur in villages, in rainforests, as I've already mentioned, and children are exposed when, for example, they play or manipulate carcasses of dead wild animals or occasionally domestic animals. So when you look at the history of previous outbreaks, the first big outbreak occurred in the mid-1990s in the DRC, but really monkeypox started to garner attention when, for the first time, an outbreak occurred outside of Africa in the United States close to 20 years ago. Since 2017, the African continent has seen a larger than average number of cases. So especially in countries like Nigeria, Cameroon, and in Central Africa, there have been large outbreaks continuously to present day. And since May 2022, the media has caught on to the monkeypox outbreak because European countries started to be affected due to super spreader events. So the current global spread started in May 2022. There is no link to travel to endemic areas to Central or Western Africa. There are few super spreader events that have been identified. Fetish festivals and also festivals in the Canary Islands as well as Belgium of homosexual people. Summer festivals have been attributed to be the triggering super spreader event for the onset of the current outbreak in Europe and North America. So far, 11 fatalities have been reported. But I really can't say the current outbreak because, as is the case in many topics, media usually give attention when things start to get out of control to high-income countries. So monkeypox outbreaks, as I've said, starting from 2017, African countries have been experiencing large number of cases compared to pre-2017 period. So as of September 2022, 95 countries have been affected, most of which are from Europe and the United States, more than 50,000 cases. From East Africa, Sudan has reported confirmed cases, and the WHO declared a public health emergency on the 23rd of July. So the African CDC even since the beginning of 2022, since January 2022, has received reports of more than 1,700 cases of monkeypox and 73 cases from, in total, 10 African countries. Since the COVID pandemic started, more than 12,000 cases have occurred in the African continent. So the outbreak that started from Europe, the median age of affected people is about 36 years, and most cases were detected in sexually transmitted infection clinics. And almost all cases presented with a rash. So this is an atypical presentation because previously monkeypox was thought to present with a prodromal period, whereby a patient will have fever, headache, asthenia, etc., and then the rash will come later. But in this outbreak, it has been shown to predominantly occur first with a rash and then the prodromal symptoms later on. So 73% of affected individuals have anogenital lesions, close to 40% have mucosal lesions, and about 2/3 have less than 10 lesions. So you can see that in most patients, there are actually not a lot of skin lesions that you can appreciate. 41% of cases, especially in Europe, had HIV infections, and 29% had concomitant sexually transmitted infections. So in adults presenting with monkeypox in this current outbreak, so screening for sexually transmitted infections, HIV, hepatitis, and other STIs should be considered, and most cases have actually been mild ones. So this slide shows the predominance of cases in the European as well as the North American regions. Also here on this slide, you see that the rest of the world is catching up. Initially, almost predominantly it was from Europe, but Starting from July, a large number of cases have been reported from Brazil and other Latin American countries, as well as other North American countries as well. So the WHO case definition is when you have clinical signs and when the illness is confirmed by PCR. When there is no access for PCR, then a probable case can be diagnosed. When you have a link to a confirmed or probable case and you are presenting with classic symptoms, and the suspected case is one which has an acute illness with fever, intense headache, lymphadenopathy, back pain, muscle pain, followed a few days later by a progressive rash, usually focusing on the face, palms, and soles. So once the symptoms start to occur, one of the noticeable symptoms is lymphadenopathy. So monkeypox, unlike the other pox viruses, presents with large lymphadenopathies, especially in the inguinal area, in addition to the prodromal symptoms that are listed here. The skin manifestations in a typical monkeypox infection present within 1 to 3 days after fever disappears. And as I've mentioned, face, palms, and soles and mucosa are affected more than other dermatologic sections. So the evolution of the rash is first you see macules, papules, and then you see vesicles, blisters, and then crusting and healing occurs. Sometimes there are cases whereby this period is difficult to recognize. For example, if a patient has severe lesions, then one lesion and the other lesion may join, and there may be large lesions that you appreciate and skin sloughing. If a patient has been vaccinated with a smallpox, if an elderly patient has been vaccinated with smallpox, then the manifestations are attenuated. And the crucial points when you try to identify monkeypox rash is the lesions are usually at the same stage. So if it is macules, they're all at the macular stage. If it is vesicles, all at the vesicle stage usually. So this contrasts, for example, with chickenpox, whereby you will see different stages at the same time. In chickenpox, you may get vesicles, blisters, macules, papules at the same time on the same patient. The other thing is it's not pruritic, but it's firm, hard, and well circumscribed. Occasionally, it may amblicate, and in adults, especially with increasing age, trunk and proximal extremities such as the thighs can also be often affected. So these are patients affected by monkeypox. You see, especially in the child on the right-hand side, that the lesions all look alike. They are all at the same stage, and you see that face as well as the hands and feet are predominantly affected. When we come to the current outbreak, so what is unique about what we are seeing now is in more than 50% of cases, the rash appeared before the prodromal symptoms. And the rash was predominantly seen in the genital as well as perianal areas, as well as the buccal mucosa. And then you get the other symptoms. And in a few patients, you also there's also a rash which has occurred at different stages, like chickenpox. So these are atypical features which have been seen. And lesions have often started from mucosal sites. Rash has often been focal rather than generalized, usually at the exposed site. For example, if this was sexually transmitted, focusing on the portal of entry, and few patients have had isolated face or extremities involvement. So the large proportion of patients with mucosal involvement is also an atypical feature that has been seen in this current outbreak. So these are various genital, anogenital lesions that have been reported in the current outbreak. You can see most of them having blisters, pustules, and genitalia, as well as the anal, perianal regions being affected more. So the case fatality rate, as I've said, with the West African variant or the clade 2 or clade 3 is about 1%. But this is exponentially high if the affected patient is a child. So the younger the patient, the higher the case fatality rates. Now, how do we differentiate monkeypox with other pox viruses? So chickenpox, I've already discussed. The lesions are more or less focused on the trunk. They are intensely pruritic. There is minimal prodromal symptom. And although occasionally we see lesions on the palms and soles, that is not a classic presentation. And the lesions are not deep-seated. They are superficial, as well as you can have multi-stage lesions at the same time. When you look at herpes zoster, it follows dermatomal distribution. It's painful, okay? It's painful. And in children, these lesions are milder. Vaccinia, which occurs following vaccination for smallpox. So this is very easy to recognize if there is this history. It's generalized and the lesions are very short-lived. Smallpox has been eradicated. There is no animal reservoir, one crucial differentiating factor. It's usually centrifugal face and extremities like monkeypox, and the rash has similar progression as monkeypox. It has a higher mortality than monkeypox, but similar to monkeypox, lesions are at the same phase. Then you have ORF or parapox, usually seen in rural regions. This occurs after animal contact. Unlike the other members in the pox virus family, it's only transmitted via contact, non-droplet transmissions, and usually lesions are solitary as well as nodular, as you see here, and usually in the fingers because these acral regions, the fingers and the hands are usually in contact with domestic animals. And then finally, you have the Tana pox. The name is because it was first recognized in the Tana River Basin in Kenya. This is a pruritic lesion, usually solitary and nodular like ORF, but it has a protracted course. And unlike the other members in this family, it has an oncogenic potential associated with regional lymph nodes and usually restricted to a few countries in East and Central Africa. Molluscum contagiosum, it's diagnosed in immune-compromised hosts as well as immune-competent children. These are very small lesions, so their size is one of the differentiating factors compared to monkeypox. Usually the head and neck are affected and they are centrally umbilicated. Another crucial differentiating factor is molluscum sparse palms and soles. So confirmatory diagnosis is by molecular methods like PCR. There are serologic tests, antigen and antibody tests, but due to cross-reaction with other members of the pox viruses, they are not sensitive tests. So you have to vigorously swab the base of the lesion with a sterile polyester or Dacron swab, and then you have to insert the swab into a tube containing a transport medium. So when we look at the management of monkeypox, it's mostly supportive, but there are up and coming pharmacologic options for patients at high risk of severe disease. These groups include ages younger than 8 years of age, those who are immune compromised, patients with compromised skin barrier like atopic dermatitis and other exfoliative skin conditions, as well as mucosal lesions. So there are few pharmacologic options for severe monkeypox. The first is tecovirimat, which is a drug available in oral as well as intravenous formulations and administered for 2 weeks. It inhibits the function of an envelope protein, which is needed for viral transmission. If you want to get maximum benefit from this drug, then you have to start early, within a few days after the start of symptoms. And it is approved for all people with weights 13 kg and above. So it's approved in the US for the treatment of smallpox, and it has also been shown to be effective in animals with monkeypox. So for all of these drugs that I am discussing, there is no adequate human trials, and any recommendations are extrapolated from the benefits of these drugs for smallpox, and especially the benefits of these drugs against monkeypox in animals. Then you have cidofovir. Usually this drug is used for CMV treatment. It's given for 5 days. This is a cytosine analog. Again, this drug is given for 18 years and above. Its brother molecule, which is birincidofir. It's an oral antiviral, which is given once weekly for 2 doses. This medication is approved for all ages. So cidofovir has been approved in the US for CMV, but it's still under investigation for extensive use for monkeypox. Birincidofir is approved for smallpox, but again, only upon expert recommendation and only for severely affected individuals are these drugs prescribed. Then you have Vaccinia IV immunoglobulin, which contains high titers of anti-smallpox or anti-vaccinia antibody. So available evidence shows benefit in the age group between 16 to 65. And whenever a person encounters a smallpox vaccine complications, the US FDA has approved its use for the treatment of those symptoms. Vaccinia IVIG is the therapeutic option with the least evidence compared to the other 3 antivirals for the management of monkeypox. So everything that's discussed in this slide is based on current knowledge, and this is an actively changing landscape. So prevention is by contact and droplet precautions. So if you say droplet precautions is if you come within 1 meter of distance with the affected individual, then you need to have all forms of droplet and contact precautions. But if patients are undergoing aerosol generating procedures, then you have to don an N95 and observe extensive preventive precaution. The other is immune prophylaxis. So smallpox vaccine has been used for immune prophylaxis for monkeypox. So the efficacy against smallpox is 95%, and usually protection lasts for 3 to 5 years, after which you need boosters. In monkeypox, it has been shown to have 85% protection, but for how long is unknown. So lab workers which are studying monkeypox virus are the population group which have the most extensive experience with smallpox vaccine administration currently. They are boosted every 2 years. And also, as I've already mentioned, Vaccinia IVIG is also useful for prevention. So in countries where smallpox vaccine previously was given, in most countries until the year 1976, individuals who are aged more up, or who are aged 46 years and above have benefited from cross-protective immunity whenever they are exposed to monkeypox, but the cross-protective immunity is to some extent because, as I've already mentioned, protective titers drop after 5 years of administration of the vaccines. And smallpox vaccine, since it is being rolled out for high-risk populations, we need to know what adverse drug reactions it carries. So it's one of the highest, it's one of the vaccines with a high rate of adverse drug reactions, such as eczema vaccinatum, encephalitis, and one form of smallpox vaccine, which I will be discussing later, is also has also a high risk of myocarditis. So if after exposure you want to prevent monkeypox, the vaccine should be given within 3 to 5 days of exposure, but can be reasonably administered up to 14 days of exposure. The whole purpose is to decrease the severity of symptoms and not complete prevention. So peak immunity in an individual is achieved 14 days after dose 2. So these are the two available vaccines which are used to prevent monkeypox as well as smallpox. So the first is called Jynneos, that's the brand name. It's a killed vaccine. It is approved for both syndromes for all ages and who are at high risk. So you administer 2 doses, 0.5 ml intradermally or subcutaneous route, 4 weeks apart. Alternatively, if a person has already encountered monkeypox infection, and if they take 1 dose, then the protection that results is considered equal to taking 2 doses. So it is less toxic than the second vaccine, which is the ACAM 2000 vaccine, and it is contraindicated for pregnant and lactating mothers, as well as for children. For the elderly above 65 years. In ACAM 2000, this is a live attenuated vaccine. And it's administered through the method called scarification. So you can see on this picture using a bifurcated needle and jabbing the percutaneous tissue, the vaccine is administered. It has a very high risk for myocarditis. Almost 6 people per 1,000 individuals can encounter myocarditis after taking this vaccine, and especially if a person has been vaccinated against COVID with RNA vaccines such as Moderna, Pfizer recently, then this vaccine is contraindicated because of double risk for cardiovascular adverse drug reactions. So who do we vaccinate? So that's the most important question. Who is considered high risk? So the first is unprotected close prolonged contact, and any individual which is present during procedures that may generate aerosols, and also people living during the incubation period with a person with confirmed monkeypox. So if an unaffected individual lives with an infected individual for the full incubation period, on average 7 days, and unprotected, then they are considered a high risk. So these individuals you should vaccinate. For medium risk, if there is an unmasked contact within 2 meters for more than 3 hours of an unmasked patient, so the contact as well as the patient are unmasked and there is prolonged contact, then that's considered as a medium risk. And the contact between an affected person's clothing and the patient's skin lesions also is considered as medium risk. And to give or not to give the vaccine is a case-by-case decision. All others which are not discussed here are considered low risk and do not require vaccinations. So patients should isolate until rash has fully resolved, okay? And scabs have fallen off completely, and they start to see a fresh layer of intact skin. So this whole process may take 2 to 4 weeks. So droplet and contact precautions should be observed for this period. Environmental control can be achieved by having a buffer zone between wild forest as well as cultivated farmlands, avoiding consumption of undercooked or raw bush meats, and relying on animal husbandry for meat source, as well as education in the handling of wildlife. Thank you very much. I will leave the floor open for question and answers.
Okay, thank you very much, Dr. Tinsae, for the excellent and very informative presentation. So the next will be the question and answer session, and Dr. Zaga and Brooke will be moderating that. Over to you, Dr. Zaga.
Thank you, Dr. Tinsae, for your excellent presentation. I'll start with the last question. It says from Tinsae Alemayehu, what are the short-term, mid, and long-term post-infectious sequelae of monkeypox?
So, sorry, can you repeat the question?
It says, what are the short, the mid, and the long-term post-infectious sequelae of monkeypox?
Okay, so thank you for the question. So the short-term complications, include secondary bacterial infection, because these lesions are present for a few weeks. So without proper precautions, then secondary bacterial cellulitis, pyomyositis, and other soft tissue infections can occur. Long-term complications, so far there have not been enough cases to follow as a cohort for many years to conclude or to identify any long-term complications. So this is to be seen as we move forwards.
Thank you, Doctor. I think we are receiving other questions as well. From Haftam Warku, it says, how much cases do we have in Ethiopia so far?
I'm not aware of confirmed cases.
Okay, perfect. So Nazanet Katama said, what best can we do for patients having monkeypox if those antiviral and IVIG are unavailable?
So the best thing, as this is a viral syndrome, is for providing supportive treatment, prevent secondary infections, and observe infection prevention, hydrate the patient well, and also provide antipyretics. So in the absence of those experimental drugs, the main thing it will be supportive treatment and try to contain the infection and avoid spread to other parts of the hospital.
Okay, thank you, Doctor. One question we have is from Tinsae Alemayehu. He says, what are the short, mid, and long-term post-infection sequelae for monkeypox?
I think we just discussed that. We are more concerned about secondary bacterial infections, soft tissue infections, after the lesions appear until they crust.
Okay, the guy Tinsae has also another question. He mentioned, or he or she mentioned, what is the safety profile for tecovirimat? I'm sorry, I can't pronounce this. Any major side effects?
So you said major side effects for
the tecovirimat and brincidofovir.
Oh, okay, the brincidofovir. Oh, so in brincidofovir, I'm also having a hard time trying to pronounce these drugs. You have to be cautious about the renal impairment, okay? Especially in patients with impaired renal function. So you have to be cautious about administering it. In some patients, seizures as well as neurologic side effects such as confusion, a lack of sleep, as well as paresthesias have been documented. For tecovirimat, the most common adverse reactions that is reported by patients is headache, but no other significant adverse reactions have been reported. But again, not many patients have received this drug. So this is an experimental drug, but headache occurs in about 1 in 10 patients who take this drug.
From Ibro, can we man-to-man with confirmed cases of monkeypox from vaccination to supportive care? Is there a teratogenic effect if pregnant women vaccinated for monkeypox?
So, because of lack of adequate evidence, the vaccines are contraindicated in pregnant individuals. So, I think the answer to this question will be provided with clinical trials if this outbreak continues to spread further than what we are seeing now. Definitely, just like the COVID vaccines, we will have the answer to that. But currently, due to a low number of pregnant individuals exposed to this vaccine, no recommendations to give the vaccines is made, and it's best to avoid if a mother is also lactating.
That's good. From another question from Anonymous, what's the definitive diagnosis modality for monkeypox and the initial management?
The best diagnostic tool is PCR. So as I've already said, this is a DNA virus, and management is it relies on supportive management. Serologic tests are present, but they are not sensitive because they cross-react with other pox viruses such as parapox, molluscum, tanapox, as well as vaccinia.
Okay. One question from Denak Acho. He said, what's the most common and life-threatening complication of a monkeypox?
I would say the most common the complication would be sepsis. So if adequate wound care, especially in patients with severe monkeypox with confluent lesions, large confluent lesions, if adequate wound care is not made, then sepsis can result due to organisms entering the break-in skin barrier.
Okay, I think the last question is going to be from Dr. Henok Tadese. He said, what are the supportive treatments recommended for monkeypox patients and any topical agents to hasten the healing?
So adequate hydration, okay, adequate hydration. No topical agents have been proven to hasten the healing process because the the presence of the viral infection from start of the symptoms until resolution of the last rush, until scarring and falling of the old lesions, is about 2 to 4 weeks. And no topical agent can hasten or shorten that clinical course or time period. So the best thing would be just to hydrate, give antipyretics, give wound care, prevent infections. And if by doing so, if when you prevent secondary infections, you also decrease the chances of sepsis and also non-suppurative complications due to those soft tissue infections as well. So that's the only thing we can do. If adequate evidence arises on the antivirals that I've just mentioned, then I'm sure the clinical guidelines will change as the year progresses, and then we can also implement that.
Thank you. I think we have 2 more questions, very important questions I saw. The first one said, should we be worried about mutation and virulence of monkeypox virus like COVID? And the second question is, does it has atypical presentation in immunocompromised patients?
So to start from the second question, in patients which have immune compromise, then the clinical manifestations are more severe. There are larger number of lesions, more severe lesions, and more confluent lesions. So definitely that group of patients deserves attention, priority for treatment, priority for post-exposure prophylaxis. Okay, so recent articles have shown that the monkeypox virus can mutate, and that may be one of the driving factors for the spread of the current outbreak. So we will watch this space, but articles which have been published since July have shown that it's a fastly mutating virus, but unless a virulent strain which leads to, apart from the clade 1, 2, 3 that we have already discussed, unless a more virulent strain which deserves early antiviral treatment across the board for all ages arises, we will stick to supportive treatment and continue to monitor the mutation cycles, the new mutation cycles, but it has that potency.
Thank you, Dr. Tinsae, for your latest information and everything. We thank you very much. I'll leave the floor to Dr. Ibsa.
Okay, thank you, everyone. It was a very informative and good presentation from Dr. Tinsae, and we'll wind up our session. So goodbye, everyone, and we'll meet again with another webinar session after a month. So good evening, everyone.
Thank you. Good evening, everyone.